Top Med Talk.
Welcome to Top Med Talk. This piece has been supported by an unrestricted educational grant from bioMérieux. They're raising awareness about their Know AKI campaign, acute kidney injury. Is it true to say that to know acute kidney injury is the first step towards no acute kidney injury? It's something we've discussed over the years many times on Top Med Talk, and this podcast acts as a refresher on the essentials of the debate. There's also a lot of links on the show notes for this podcast that we strongly recommend you have a look at. It'll give you an opportunity to listen to the fuller conversation of these pieces that we're about to be listening to on the podcast today. This first piece gives us a sense of where the debate is, particularly as regards the Know AKI campaign. Desiree Chappell and Monty Mython with their guest Michelle Chu, Professor, Senior Consultant, Faculty of Medicine at Linköping University. Have a listen.
That some centres in the USA, one in particular, is reporting that they seem to have almost eliminated acute kidney injury.
Oh, really?
Yes, by a very, very proactive. Well, they have the luxury of all patients going to a critical care environment. Two is they almost universally have hemodynamic monitoring with all the different platforms available and echo. And now they've been using these kidney stress markers.
Yeah, the biomarkers.
Nephrocheck, for example. And getting onto the patient quickly if there's a hint of renal pain. And maybe it's the same thing with troponins and myocardial injury.
Yeah, I guess the evidence for using individual triggers or whatever is not quite there yet. But perhaps the lesson that we can learn from that is being on top of things, preventing things from getting too bad without noticing it, and coming after the fact.
Yeah. So how you talked about your workshop, and we're talking about these, post-op AKI, and all these are in your workshop. How did you talk to the group about getting into the post-operative space? Because again, we had this conversation last night that I think anesthesiologists do a really good job about the pre-op piece, but you said extending it out. And we know that as we talk to people, people just don't know their rates of AKI and things like that. So were you addressing that?
Yeah, the question that I asked, the audience, and you were into this, Monty, because I remember you giving I think we had a workshop together at the Geneva conference. Yeah. You could ask any anaesthetist and they would be able to tell you how many patients suffered a major event or died on the table. They'd be able to tell you that in the last year. They might be able to tell you how many patients had a major adverse event in the PACU or had died in the PACU. They might be able to tell you that. And then you go in and ask them, how many of these patients died in hospital?
They don't know.
They don't know. How many died within 30 days?
Most don't know.
Most don't know. Right, unless you're regularly auditing your numbers. Within 30 days, within 1 year, within 5 years, most anaesthetists and even surgeons for that matter don't know that.
Yeah, I just find that fascinating because we're trying to move the needle on that, and it's really difficult when people just don't understand what their outcomes are.
So at Anesthesia 2019, last month in London, we had a panel which included a senior representative from NHS England, who is a surgeon, female surgeon, Celia Ingham-Clark, who talked about the new vision for the long-term scorecard. It's not there yet, but she's just describing a vision whereby you'd know the whole of the patient's surgical journey, from when they had their surgery, what went into them, what was taken out of them. And the team players would be listed on the card, if you see what I mean, that would then stay with them. And a year later, you'd know the outcomes, because, and it wouldn't just be the surgeon. You'd list the anaesthetist, you'd list the nurse that was involved, you'd list the pharmacist involved, such that if there was a mistake with a drug and they got acute kidney injury, they could reflect on that might be related to it. I think that's a brilliant idea.
Yes.
So I was just talking to, I think it was Dave O'Connor from MSK, Memorial Sloan Kettering, and saying that they have a dashboard that's been created that's showing them post-operatively if their patients are coming up and they're getting pinged for, not dinged, but they're getting, they're letting them know if they have a patient with a post-op complication. Which I think is, absolutely. We need to know,
Yeah, we need to know. If nothing else, just as a reflection, as some sort of reflection on the work that you've done, because, we all do our best.
Yeah.
We all do what we think is best for the patient. And if we don't measure, the outcomes at an appropriate time point, then you can't really make that judgment. And in that way, I think the NHS is doing an amazing job. It's the only country. Well, the NSQIP has a similar kind of program, but I think the NHS is very much more inclusive with the whole perioperative group. And we don't have that in Scandinavia, and perhaps you should come and talk to
no one listens to me.
They don't listen to me either.
Taken from our coverage of Euro Anesthesia 2019, Michelle Chu there. In this next clip, Desiree Chappell with her guest Andy Shaw, president of the Society of Cardiovascular Anesthesiologists, speaks about the perioperative quality initiative. This piece was recorded live at the 2019 Society of Cardiovascular Anesthesiologists annual conference.
Well, I wanted to touch on POCI quickly before we leave. Andy, you are also a member of this organization. Can you tell us just quickly, POCI, Perioperative Quality Initiative?
That's right.
We talk a lot about it. You guys have just had some papers. You want to plug some of the stuff that's been coming out?
So we are literally just planning now our 7th meeting, which will be in Cambridge in the UK this year, focusing on acute kidney injury. Not in the context of heart surgery, because that was done by the Acute Disease Quality Initiative this time last year, ADQI. So POCI is a perioperative version of ADQI, which is now in its 24th, 25th iteration. And the goal is, just like at CPI SCA, is to try and distill the literature in a specific clinical problem area down to a format that's accessible. Typically, it's done by a modified Delphi framework with a conference that lasts over 3 or 4 days. There's a backwards and forwards discussion. There's usually 3 or 4 focus groups, each of whom produce a paper. And we've done that reasonably successfully. We've published everything that we've done so far. It's all available at poci.org. All of the infographics and the images are held by POCI, and they're freely available for people to use in their educational programming. So, poci.org.
So, what are the options here? It's a complicated picture and a debate that shifts as more data is discovered. This is taken from one of the first programmes ever streamed here on Top Med Talk 2017. Professor John Kellum, tenured professor, critical care medicine, University of Pittsburgh, gives us a thumbnail sketch summary of the fluid debate whilst in conversation with Professor Monty Mython and Dr. Geoff Lacey.
So, thumbnail sketch summary of the fluids.
Yeah, so of course fluids and the whole controversy regarding the volume, composition, and I think perhaps a recognized part of that is the rate of infusion, the bolus issue. And so, again, we're reminded that composition of fluids, volume of fluid, rate of delivery is important. And I think one of the things to me that I keep having to be reminded of is that one of the reasons that this has continued to be a problem is that I don't think we as clinicians necessarily appreciate that there's a cost to pay in terms of harm with giving an intervention like giving a liter of fluid. We just say to ourselves, well, it may not be the right thing to do, but it's rarely the wrong thing to do. And I think we're appreciating that, particularly when that happens again and again. It often is the wrong thing to do, and patients develop volume overload. It prolongs their hospital stay. It may prolong their ICU stay. It may lead to complications which are otherwise avoidable. And we're seeing this again and again.
And what I heard you saying is that, when I was a young doctor, you sort of got the impression that if you got the kidney to handle a lot of fluid, somehow it would be happier. Isn't that just kidney work?
Well, I think that is the prevailing wisdom, and like many prevailing wisdoms, it is incorrect. The kidney is in a capsule. It doesn't particularly like to be challenged with volume from simply from a pressure standpoint. But in addition to that, the volume that we give contains a lot of sodium and sodium chloride, and the kidney is the organ that has to handle that has to get rid of that sodium load. We have to remember that there's 9 grams of sodium chloride, 9 grams in a liter of 0.9 normal saline. And so that's quite a lot when you consider what a cardiac diet of 2 grams of sodium is in a day. So I think we have to remember that.
Yeah, I think as was mentioned from I think one of the delegates in one of the later sessions, we really do have to start looking at intravenous fluids as toxins, as well as therapeutic intervention. They really do have significant side effects that we don't always pay attention to, and kidney injury being a prime example.
So we probably didn't emphasize enough in the introduction, John, that you've got a bit of a kidney pedigree, I think. So your title back home is what?
Yeah, so I direct a center for critical care nephrology, and that raised some eyebrows when we opened it a few years ago. So, well, you're not a nephrologist. Why are you wanting to have a center for critical care nephrologist? Well, like perioperative medicine, I think that nephrology is an area that contains certain expertise that is specific to fluids, to acid base, to acute kidney injury. These are things that I've spent my entire career investigating, and I think when we started, it was very unclear that these were big problems, and we now understand that they all are. So the center that I direct focuses on those and brings in intensivists, nephrologists, surgeons, anesthesiologists, and many others, actually, who are interested in this.
And the POQI, the Perioperative Quality Initiative that we discussed and in previous podcasts, that's based on ADQI, the ADQI.
The Acute Dialysis Quality Initiative, which was rebranded as the Acute Disease Quality Initiative as we've expanded into some of these other areas. Of course, I'm quite gratified to see a sister organization sort of emerge as the POQI and up the methodology that we developed some 2 decades ago to try to coalesce both evidence appraisal as well as the importance of expert opinion.
So it seems that no one doubts that fluid resuscitation is very important when it's needed. So the patient who's hypovolemic, who's dying from lack of volume therapy, it's a lifesaver and it's an organ saver. I think the area of great confusion now is when that patient is established in the critical care unit and they're often many litres positive. Why do we keep watering them on a daily basis and feeding them salt?
Well, it's a good question. I think the answer is complex, but I think part of it has to do with the fact that it's an intervention that doesn't seem to require too much escalation, right? So you can you can hang a bag of fluid without, calling anyone. Junior doctor can do that without seeming to need to escalate the therapy of the patient. It doesn't need to move the patient, into a higher level of care, for example, if the patient's in a step-down unit, for example. That's, I think, a very important aspect, putting the patient back on vasopressors after they've been weaned, even if it might be the right answer, seems in many people's minds to be much more of an invasive type of thing. It's stepping back. Whereas if I can just solve the problem, at least for my shift, by giving a liter of volume and going away.
And I think that's a very good point. It does temporarily solve that problem. So getting people to not do it is a hard job.
It is. It's a very hard job. And I think one of the things that the era of big data, I'd like to push Dan and others and our own database to look carefully at whether you really do anything with giving this sort of fluid therapy other than just buy some time. Does giving fluid to a patient who's vasodilated do anything other than buy you the shift or maybe a day before you then have to say, okay, now I'm 3 liters positive, 6 liters positive, 9 liters positive, and I'm still in trouble. I've got to go back on this therapy.
John, you showed us some data from the multi-center trial published in the New England Journal of Medicine, I think, which was the early goal-directed therapy trial. And you had 3 groups, didn't you? And one of the 3 groups was the unexpected outlier. Was I right in...
Yes, this was a study in sepsis, and the use of early goal-directed therapy in that setting involves is a complex algorithm of things like blood products and vasopressors and inotropes and vasodilators. We had a third group, which was in order to deal with the fact that if you're just randomizing people to usual care versus a complex algorithm, you have a Hawthorne effect. And we wanted to be sure that the team and the protocol itself wasn't somehow driving any potential outcome, any potential benefit. So we had a structured resuscitation protocol that was very much what we, sitting around talking about what intensivists do at the bedside, sort of do, but in a structured protocolized way. And because it was a structured protocol, it tended to give more volume than either of the other 2 arms. And what you're referring to is the fact that actually, if you look at the data carefully, you see that there is no benefit in terms of mortality, but the morbidity signal actually goes the wrong way. The more fluid that you give seems to be associated with, and in this case, causally, with more morbidity, including renal dysfunction.
That was this third group. So it wasn't the early goal-directed group or the control group. It was the third.
It was this what we call the protocolized standard therapy group.
And they ended up receiving more renal replacement therapy.
They did.
And one of the things you didn't allude to today, which I've become very interested in, that group had a higher CVP.
It did indeed.
Yeah, I don't know if the other guests here are aware of this. That seems to be a recurring theme if you look closely at some of the literature. If you look at some of the fluid trials, I mean, doesn't the kidney like a high CVP?
It doesn't appreciate a low CVP or a high CVP. It appreciates a more normal CVP, like many of our other organs. And the reason for that is that there's back pressure on the kidney. If the right heart fails or simply becomes volume overloaded, the perfusion pressure in the kidney is going to be diminished. And particularly when we speak of things like a mean arterial pressure of 65, 65 against a CVP of 4 is different than a CVP 65 against a CVP of 24.
So that's worth people looking very closely at, because it's a little recurring theme in there.
It is indeed.
Chest trial, which addressed a different questions, colloid, crystalloid, higher CVP, more renal replacement therapy. It's an association, not making too much of it. Urine output, because sorry, Tim.
I was just going to be clear, we didn't actually name the trial. So just for the listeners, this is the process trial.
This is the process trial, that's right.
You're speaking about.
Urine output, very briefly. Do we have to still measure urine output?
Well, we do, and maybe not during the case, because intraoperative urine output has a variety of other issues related to it. I guess I wouldn't say don't measure it during the case, but it means something different intraoperatively. Perioperative urine output, though, is a vital sign and is strongly associated with adverse consequences.
So, what about goal-directed fluid therapy to prevent AKI? Here, Vincent Dentini, Senior Staff Specialist and Nephrologist at Alfred Hospital, Melbourne, explains more.
Now there's some evidence coming along about balanced or physiological fluids being somewhat better. Let's go through them. We knew around 2000, when it was early goal-directed therapy, which is with aggressive hydration and maintaining MAP, we found out that actually had no effect on mortality or need for renal replacement therapy. We also know that fluid overload is very bad. Swollen kidneys, compartment syndrome, decreased renal perfusion, venous engorgement are all bad for AKI. And there are numerous methods to assess fluid responsiveness, but unfortunately in isolation, one is not perfect. So I've got lots of those gadgets involved, but none of them are perfect to help us along. But in the end, we need to use our IV fluids judiciously, and in patients with AKI, be careful if they're not fluid responsive. So, colloid versus crystalloid. In 2004, the SAFE trial, a very good trial centred out of Australia, New Zealand, told us that crystalloid is as good as colloid, except for certain situations. And crystalloids is probably the way to go over colloids, because we know that colloids is expensive. However, we still have a lot of use of colloids or albumin in our practices, and it's usually because of a culture or doctor's preference, and despite the good evidence. That was in 2004, and then the Crystal randomised trial came out, and that was in 2013, and that compared effects of fluid resuscitation with colloids and crystalloids on mortality, and they also found out no difference in renal replacement requirements or mortality at 1 month. So once again, crystalloids look like they're in, colloids seem safe, more expensive, and the next question is, what type of crystalloid? Are you using a balanced or a balanced solution, like a Hartmann's or Ringer's lactate, versus a normal saline? And as I said, hypochloremic metabolic acidosis is certainly on point with research and looking at its deleterious effects. And we know in animal models it affects the kidney, and also in human models that it affects the kidney with decreased renal cortical perfusion and in salt loads patients. So the Saltum study, published this year in 2008, addressed crystalloids versus saline in critical ill adults, and that found out the balanced crystalloids actually lowered the rate of composite outcome of death from any cause or persistent renal failure, chronic kidney disease. However, as much as it was a very good study, and people are now sort of ditching, it's not time yet still to ditch the saline, because it was a single centre study and there was a few limitations to this study, and people now, before they decide whether saline's still in or out, they're waiting on this PLUS trial, which is Plasmolite versus saline, which hopefully will be published in the next year or two. So with fluids, type of fluid, we know crystalloids are certainly in. We're not sure what sort of crystalloids. What about the volume? What about restrictive versus liberal? We previously were very aggressive with fluids, and we know that that's not right, then we'll become restrictive. And a lot of the patients come back from theatre pretty dry. We hear dry you fly, wet you sweat. But this article has just came out only a few months ago, and we found out that restrictive versus liberal fluid for major abdominal surgery, restrictive was associated with a higher rate of acute kidney injury. So now we think what fluid is better and how and sort of what volume or which way to give it, and this is now more controversy and more lack of consensus. And we're now going into care bundles. I don't know if people have been getting care bundles, but do you want a kidney bundle, a respiratory bundle, a cardiac bundle? How many bundles can we handle? But I really think with the electronic medical record coming, which will pick straight away that you've got an AKI and a stage, because it'll pick up the creatinine going off on 2 consecutive tests. That'll launch, hopefully, something like, be wary, you're in AKI, this is preventable, let's not go down that rocky road. So this is this is sort of what's happening in the world. We've got all these people forming networks, and you've got Stop AKI checklist. You can see the Stop AKI, Think Sepsis, haven't got my glasses, Think Hypoperfusion, toxicity, etc. But there's also this lovely little quality improvement study that someone did in the UK, and it's called the Donut Study. And basically they thought it actually did work, and they did actually identify more AKI. And it's very simple. It's dehydration, obstruction, nephrotoxins, urine, and Think Sepsis, which is probably what I've sort of covered through this talk. I think if you gave a staff member a donut, you'd probably have more uptake. And this answers this question: do care bundles really work? And the truth is, as much as I'm not too much for protocolized medicine, but they actually do work. But the problem with the bundles are the uptake. So when people use them, they're very effective, but you've got to get people to use them. And that's the big problem with these bundles.
Brought to you by the Perioperative Medicine Special Interest Group in association with Top Med Talk back in 2018. This brings us to the RELIEF trial, which stands for Restricted versus Liberal Fluid Therapy in Major Abdominal Surgery. This piece taken from a podcast called The Big Trials, EPOM, London, 2018. Any answers? Paul Miles, head of Alfred Heath's and Monash University's Department of Anaesthesia and Perioperative Medicine and the organiser of the trial, here gives us the results.
Patients undergoing major abdominal surgery, a restrictive IV fluid regimen designed to achieve zero balance during surgery and out to 24 hours after surgery did not reduce serious complications or hospital length of stay, and it did not improve disability-free survival. However, that restrictive regimen was associated with a higher risk of acute kidney injury and other serious complications. And if you're using any sort of fluid responsiveness monitor, a goal-directed device, the effects do not change. If you are a high-functioning ERAS hospital or not, the results do not change. They apply equally in both settings.
EPOM 2018, and Professor Monty Mython asks a slightly naughty question of Paul Miles and Professor Rupert Pearce, Intensive Care Medicine at Queen Mary University of London Hospital. Rupert, of course, was arranging a trial called the Optimise 2 trial. Have a listen.
Observations about cardiac output monitoring, and it's just down to giving everyone 3. You seem to be doing a very, very large, expensive trial. Why don't you just give it up?
Ask very provocative questions. I think it's very helpful. I think what Monty's referring to is the Optimise 2 trial being led by Rupert Pearce, which is effectively, I won't explain the details of the trial, but it is to sort of enhance effectively cardiac output and therefore hopefully organ blood flow in the perioperative period. And we are contributing or participating in Optimise 2 at our site, our hospital in Australia, as are quite a few in Australia and certainly around the world. My very strong view is that is a crucially important question in perioperative medicine, and I think even after relief, the importance actually is even greater still. It's actually a different sort of question, but it will really, I think, help put another big piece in the puzzle of optimal perioperative care.
Thanks, Paul. While I gather my thoughts, I mean, I think the first thing is that the philosophy of optimise probably pitches very close to where you are with your Liberal group in Relief anyway. That is, but it's a treatment algorithm. It's not a cardiac output monitor. There is a cardiac output monitor in that algorithm. And in the same way, Relief tested two different algorithms. And that's what we're doing in Optimise 2 is we're comparing usual care, whatever people usually do, to a treatment algorithm. And that treatment algorithm has a monitor in it. But if I understood correctly, you didn't make any mandated requirements on what people did with the cardiac output monitor. And that's probably quite a key difference. The other thing that I think is really, really fascinating about Relief and Optimise 2 is the first Optimise trial, the big treatment effect was in infection. That's where all the treatment potential non-significant benefit existed, and Optimise 2 has been powered specifically to see whether we can improve rates of surgical site infection and so on.
Finally, this brings us to the summary which our editor-in-chief, Monty Mython, gave of these trials, including the Fedora trial and the Impress trial. Have a listen.
So how do I put those three papers together? Well, the world's changing the whole time. It's great. New big trials coming along. Optimise 2 is coming. Floella is coming. I think there are other big trials going on around the world. There are quality initiative endeavours. The Foutier trial, top left, I think we all agree we should continue to take blood pressure seriously, but probably should pay a little bit more attention than maybe some of us have been doing for a few years. And I think there'll be a growing interest in whether or not one can safely use peripheral norepinephrine infusions in patients who are at greater risk to keep that blood pressure up. And I think there's large trials need to be done to try and determine the safety-risk balance there. Fedora, I just think reinforces what we've known from the meta-analysis forever. Not forever, for the last 20 years, forever in EBPOM anyway. And Optimise 2 may or may not give us a definitive answer to that. Optimise 2 has a different algorithm. It has a different technology. It has different interventions. It has different endpoints. It's a very good, important, large trial, but it's not exactly the same. And then there's Relief, and I'd say hopefully with Relief you at least know that running patients on the drier side, which would include zero balance, is probably not in their best interest. And that rule of 3 is a great start. Why do I think the question is still alive? This is a little bit naughty, because it's naughty. This is putting on a single graph the AKI rates from Relief and the AKI rates from the Fedora trial, which is the goal-directed hemodynamic therapy trial. So when you look on this side, you've got the restrictive group from Relief and you've got the control group from Fedora. Remarkably similar rates of acute kidney injury of about 8.5%. If you then look to the other side, you've got the moderately liberal group from Relief and the AKI rates are down to 5%. If you look at the goal-directed one, the AKI rates are down under 2%. And when you look at the meta-analysis of the active hemodynamic trials, they're closer to that 1 to 2% than they are to the 5%. It's a little bit naughty, as I said, it's very naughty, because you shouldn't really be comparing trials in this way, but that's why I think this question, as we all do, remains alive. Because it may be that the more proactive management of hemodynamics produces even better results than careful, meticulous fluid management, which would appear to be rare in its own right, and choosing to be moderately liberal compared to restrictive.
So, goal-directed fluid therapy. We get more detail from Tim Miller back in 2017, where he speaks about permissive oliguria and goal-directed therapy. Have a listen.
When we implemented in our enhanced recovery pathway, typical of implementation of any enhanced recovery pathway, we made a number of changes to our fluid management. We allowed clear fluids until 2 hours preoperatively. We gave a carbohydrate drink. Perhaps a little differently to some other centres, did goal-directed fluid therapy for every patient within our enhanced recovery pathway. So that was a big change from beforehand. And then post-operatively, we got the IV down very early, often in the PACU, if not on post-op day 1, allowed permissive oliguria of down to 10 mils per hour, as long as everything else was okay, and got the patient up and about, drinking, eating, mobilising. We also had an epidural rate of around 90%, so may have had a little bit more hypotension than we had before. So one of the questions we wanted to ask was, this seemed to be good for the gut. We knew we were reducing our GI complications, reducing length of stay by 2 days, but were we harming the kidney by doing this? So we looked at about 500 patients in our enhanced recovery pathway, compared them to a previous cohort, and there was actually absolutely no difference in the levels of AKI, which was actually pretty low in each group at around 3%.
So when I read your original anesthesia and analgesia paper, which I think was one of the first from the latest era of the spread and adoption of enhanced recovery in the USA, I took from that you got everything you expected to get from introducing an enhanced recovery program. So outcomes were better, length of stay was shorter. It was all good news from that perspective. But reading the paper, it seems as though you gave less fluid overall from that first initial tranche. Is that true? The amount of fluid you gave went down?
Yeah, we gave more colloid and less crystalloid, but overall less fluid.
So let's walk through the steps then from the beginning, because there's often a suggestion from some people that goal-directed fluid therapy equals more fluid, whereas as we touched on yesterday, we're now hearing people talking about goal-directed fluid restriction. In other words, used appropriately, you end up giving less fluid, but you're confident you're giving the right amount of fluid. So from the beginning, again, in your enhanced recovery program, tell us just about the preoperative fluid components of it, the bits before they get to the OR.
So beforehand, patients were nil by mouth for midnight, and that was universal, and still is universal in a number of hospitals, even if your surgery is at 4 p.m. that evening. So we changed that to allow clear fluids until 1 hour before arrival, which is typically 3 hours preoperatively. And we did that to give a little bit of wiggle room just in case the surgery was moved forward. And we gave all patients a carbohydrate drink, which again they drank 1 hour before arrival. And I think the advantage of giving the carbohydrate drink, as well as the possible metabolic benefits, is the patient was given this prescription type drink from the preoperative clinic, and they were told they had to finish this on the 1 hour before they arrived in the hospital. And most patients did. So rather than just having a few sips, they actually had the entire drink, and they would generally bring the bottle in. So that was our preoperative changes in management. The idea, of course, to bring the patient as much as possible to the operating room in a fed state and not hypovolemic when they arrived in the operating room. And then, as you said, intraoperatively, we divided fluids into maintenance therapy and volume therapy.
John Kellum now explains renal injury biomarkers and urine output from 2017.
There is some hope from some novel biomarkers.
There is indeed. And these markers, what we call cell cycle arrest biomarkers, are markers of the kidney's own effort, and I'll try to explain this quickly, its own effort to protect itself, because epithelial cells in the kidney, renal tubular epithelial cells, are very sensitive to environmental stress, like the epithelial cells in your body. And in that setting, the kidney protects itself when it thinks that there is potential harm. And we're finding that signal emerging into the urine, and then we can measure that signal. And it tells us something we don't otherwise know, because remember, kidney injury is otherwise silent. You don't have pain with kidney injury, but these biomarkers tell us that the kidney is under stress. And it doesn't always mean just because the kidney is under stress, something bad is going to happen. But if it's under stress, it should alert the clinicians that, wait a minute, maybe there's something, maybe this medication's a problem, maybe there's undiagnosed sepsis, maybe there is a perfusion pressure issue, maybe there's something we can do.
And these are now FDA approved, they're commonly available, they're being used clinically?
Correct.
Okay, and throw me a
tissue
name.
Inhibitor of metalloproteases 2 and insulin-like growth factor binding protein 7. If you can't remember that, Nephrocheck is the trade name.
Nephrocheck. Much more catchy, I think.
Yeah, I think so too.
Nephrocheck. Okay.
And can I just ask, is that being done preoperatively for a risk stratification process, or only after an insult that you
these markers detect acute stress. So if I stress the kidney and the markers go up, it means something. Prior to having any stress, they're not markers of frailty, for example.
Gotcha.
And I was very interested, John, you mentioned one study where they tested these markers and then they intervened and they were able to reduce the incidence of AKI. Can you just mention that in a couple of minutes?
Yes. Alex Arbach's paper in Intensive Care Medicine, I invite you all to read that. It's an excellent example of how we can use these markers.
Urine output, very briefly. do we have to still measure urine output?
Well, we do, and maybe not during the case, because intraoperative urine output has a variety of other issues related to it. I guess I wouldn't say don't measure it during the case, but it means something different intraoperatively. Perioperative urine output, though, is a vital sign and is strongly associated with adverse consequences.
But at the level, so the magic number is still debated, because there is some observational literature that says a little bit lower is probably okay.
Well, and I think what you have to say is that inferring numbers from an ICU cohort where the average fluid given to patients is 3 liters in the first day. It's the average. The mean is 3.2 liters in the first 24 hours and 2 liters per day after that is the mean. In a perioperative scenario, when you're trying to minimize, such as in colorectal surgery, where you're trying to minimize fluids, the amount of fluid that you may expect in urine output may be a bit lower. The human body needs to have a certain amount of urine output to excrete the solute load, but that's lower than the amount of fluid amount of urine output that's necessary to excrete the volume that patients typically get. So if you're in an environment where you're giving patients less volume, you may be right that a lower urine output is a reasonable target. In the ICU, we're still at very high volumes, and therefore oliguria is still a very strong vital sign in that setting.
Tim, I think your institution in the post-operative period, you practice permissive oliguria. Is that right?
Absolutely. So we've analysed over 1,000 patients now where we've practiced permissive oliguria in our enhanced recovery protocol, and we've shown no difference in creatinine values compared to a previous cohort. And I think, aligning with what John said, we don't ignore...
They're peeing, aren't they?
They are peeing. Yeah. They're peeing 20 mils an hour, for instance. But we don't ignore the urine output. But if the urine output is 20 mils an hour, the blood pressure is good, everything else is looking good, the patient says they're not feeling thirsty, this may be part of their normal stress response to surgery. And we wouldn't necessarily chase this with fluids. And frequently I find if you do chase this with fluids, you don't actually pick the urine output up. So your intervention doesn't actually help. Obviously, if there's another situation where they are hypotensive, the low urine output, and again, in that situation, it may be the right thing to do is to raise the blood pressure rather than actually to give fluid.
And that's a fully developed enhanced recovery program. You've done the pre-hydration, you've done the goal-directed therapy.
That's a very important point. So all patients get goal-directed therapy. So we're fairly comfortable that they're leaving the operating room in a full state with a good stroke volume. So if they're in that situation, if their urine output over the next hour or two is a little bit low, we can be more comfortable perhaps in not intervening, particularly with fluid.
Well, and I think you said it exactly correctly. It's not that you ignore urine output. It's still an important vital sign. If somebody in this setting had a very diminished urine output, all of a sudden you'd pay attention to it. And you wouldn't necessarily treat it with volume. I think that's the most important thing, is that, like a tachycardia, which is another vital sign that we see frequently, the treatment isn't give a beta blocker. The treatment is to understand why the patient is tachycardic. And so I think what we're saying is that urine output is still an important sign to monitor. That doesn't mean that all urine output decrements should be treated with at all, and if they should be treated, they should be treated with fluid.
In this next clip, Monty Mython and Mike Grocott are joined by Dr. Dan Sessler from the Cleveland Clinic. Here they are, live from Boston at the American Society of Anesthesiologists in 2017, providing some of Top Med Talk's world-famous live coverage.
Anesthesiologists have always managed blood pressure, but we never really knew at what level to manage it. And a reasonable question, of course, is why, after 160 years of anesthesia, we don't know this already. There actually is a good answer, which is that you need big data. This is not something you can do anecdotally, and it's not something you can do in a few hundred patients. You need tens of thousands of accurate minute-by-minute blood pressure recordings to do this sort of analysis. We've now looked at hypotension under a variety of circumstances in the operating room, in ICUs, on surgical wards, and what we find is that moderate levels of hypotension for short periods of time are very strongly associated with myocardial injury, acute kidney injury, and death.
So We heard, again, we're very shocked by this. So as little as 1 minute. Is that right? The association is there for as little as 1 minute.
By the time you get to a mean arterial pressure of 50 millimeters of mercury, 50 millimeters of mercury during surgery, it takes 1 minute to significantly increase risk. Now, understand, this doesn't mean that everybody who gets to 50 has a myocardial infarction or dies. What I'm saying is that it increases risk by a statistically significant amount.
So Tim Miller, were you shocked by that?
I think I appreciated that hypotension caused harm, but was I shocked by the fact that 1 minute caused a statistically significant increase in harm? Yes. Was I also shocked by the fact that a third of these events occurred between induction and incision, so were purely influenced by anesthesia? I think that's the second yes.
Now, this is a very special conversation, and it reflects a discussion that was held at the Perioperative Quality Initiative. This in 2018. For the first time ever, Top Med Talk exclusively streamed live some of the conversations which became part of the consensus document. It originally ran under the title Intervascular Volume and Fluid Responsiveness. With a genuinely multidisciplinary approach on display here, this piece gives you a glimpse at the inner workings of the POCI process. Desiree Chappell leads the conversation with Mike Grocott, David Kaufman, Associate Professor, Director of Medical Intensive Care Unit at NYU School of Medicine, and Dr. Greg Martin, Research Director at Emory Critical Care Centre.
Just to kind of dive right into it, I was just hoping that, Greg, you can kind of start us off and tell us about where we started with fluid responsiveness and intervascular volume and where we were starting with that.
Right, that's a good question. And it's really started because it's such an important topic that has relevance in almost everything we do for patient care. And when you think about the two components together, the fluid status, intravascular volume component, we often think of that, particularly over years, more about fluid responsiveness, helping us understand whether giving fluid would be beneficial for the patient. And as we work through this, we realize that there's a variety of limitations to intravascular volume, both in the measurement of it and the interpretation of it. So we've evolved our thinking a little bit through the last couple of days to think much more about ways that fluid status can change in an individual and the role of venous capacitance and how that's an important factor in mobilizing fluid in response to hypovolemia, for instance, and really the evolving thinking around that so that we can better help people to understand that role, or the role of venous capacitance, for interpreting the use of fluid responsiveness and measures for fluid resuscitation.
I mean, I think that what we're trying to help our readers eventually understand is when we as clinicians decide to give intravenous fluid, how is the fluid going to help a patient? It's helpful to break that down into a series of steps. And we believed as a group that it was important to understand the venous return to the heart as one of the first important steps on the pathway of intravenous fluid potentially helping a patient. And we thought that the concept of venous elastance and capacitance is an important idea that our readers and our listeners start to understand and how to interpret all of these other topics in fluid responsiveness.
Yeah, because one of the things we talk about in POCI, or this session, was the physiology, but then the clinical implications of it.
Yeah, so there's a couple of really important concepts. One is that overall, when we think about fluid therapy or other therapies we're using in patients in the perioperative setting, the overall goal is usually targeted at the macrocirculation because those are the things that we can measure and we focus on those. But the goal is often really to make sure that we're supporting or enabling normal cellular function to the extent that that can occur. And if we think about that as sort of the overarching goal and sort of presuming that then leads to better patient outcomes, that's part of that goal. And then we think about, okay, how does the amount of fluid that someone has and recognizing the limitations of intravascular volume, you can then start to think about venous capacitance, knowing that the majority of blood in an individual's body is in the venous system. So moving that system to mobilize fluid, for instance, if someone begins to become hypovolemic or hypotensive, mobilizing fluid from what we call the unstressed volume, that volume that's not necessarily participating in sort of the normal blood pressure or the response of fluids. That can then help to do this. And there are interventions that we use, like vasopressors or things that would influence that as well. So to begin to pull all those pieces together and say, venous capacitance is important. We realize that a lot of the blood in circulation is actually in the venous system, and a lot of the interventions we do are actually targeted towards that, but it also helps us explain why fluid resuscitation may or may not work. Sometimes we give it and it doesn't have the expected effect, or the other things that we do, like alpha agonists or catecholamine drugs, would actually affect that as well. And that helps us to better understand the goals of restoring normal perfusion or addressing the impact of patients in a perioperative or critical care setting.
Dan Engelman is the medical director of the Heart, Vascular and Critical Care Units at Bay State Medical Center. Here he is speaking about this issue at EPPOM Chicago 2020.
The early detection of kidney stress and interventions to avoid kidney injury is a 2A/B recommendation. That's my favorite because I've effectively eliminated acute kidney injury following cardiac surgery with that strategy. Some of the other ones that are really going to shake up the societies when they come out are right after that, the rigid sternal fixation recommendation as a level 2. That's a big deal because cardiac surgeons like to use wire cerclage, and rigid sternal fixation has an inherent cost involved. So that's a big deal. And the prehabilitation one's also groundbreaking. One of you hinted at this. That's number 3 there. And basically what I'm getting at, and I haven't really spelled it out yet, but elective cardiac surgical patients need to wait 2 to 5 weeks prior to cardiac surgery in order to prehabilitate to reduce their post-op poor outcomes. And those are patients with any degree of immobility, frailty, malnutrition. Smoking cessation needs to be a component, hazardous alcohol use, and high hemoglobin A1C. All those patients need to go to prehabilitation, and cardiac surgeons do not like that recommendation because as soon as they see a patient, they like to put them on the schedule the next day so their partner doesn't steal them and do the case.
The links to all of these pieces are, of course, available in the show notes to this podcast. Another piece from Dan Engelman now. Here, he's in conversation with Desiree Chappell and Monty Mython at EPPOM Chicago 2020.
Your rate of AKI down to 0. First of all, how is that possible? And second of all, do people actually know what their AKI rates are after surgery?
So in the year that we did our trial, we had 1 AKI. So it wasn't 0, but it was almost 0. 1 case of AKI. And that's stage 2 and 3 AKI. So it's a very liberal definition of AKI by the KDIGO definition. Yeah, so how did I reduce AKI? Well, first of all, I think the most important thing we need to talk about when it comes to AKI is that any AKI is horrible. It reduces both your short-term and long-term lifespan. That's the first problem that people don't realize. They think cardiac surgeons as a whole think if you have a bump in your creatinine and it comes back to normal while you're in the hospital, problem solved. But it turns out you never get those nephrons back. They never come back. And the so what of that is you don't live as long. And why don't you live as long? Because you have a significantly higher risk of going into CKD as you get older. So that's the first thing. And the second is that we need to pay more attention to preventing this from bumping. Creatinine is a ridiculously delayed marker. By the time the creatinine bumps, the kidney has already the nephrons have died. So we need to prevent the creatinine bump, and we need to use novel biomarkers, and we need to use more attention to goal-directed fluid therapy to actually prevent postoperative AKI. And that means that we don't go into a patient's room who has a decreased urine output and has received a fluid the prior day in the operating room and say, well, they need Lasix. You have to actually look at the patient. Just because they have fluid overload does not mean that that fluid is intravascular. And you need to look at the patient and see if they're fluid responsive. Some patients need Lasix. Some patients need volume. Some patients need an inotrope. Some patients need an echocardiogram to figure out whether they have cardiac tamponade. But you need to actually spend some time at it, and you can prevent AKI.
EPPOM USA 2019 TRIPOM. Trainees with an interest in perioperative medicine. They're an EPPOM partner, and this piece is presented by Robin Schiller and Bridger Back, with their guest, Dr. Mike Grant, Assistant Professor of Anesthesiology and Critical Care Medicine at Johns Hopkins University School of Medicine.
The anesthesiologist isn't the only person giving fluids during the case. The perfusionist can do that as well. What have you guys implemented at Hopkins?
Yeah. So I think these are two kinds of questions, but they're interrelated. So we'll start with perfusion, because perfusion really for everybody is this big black box that's kind of happening in the side of the room, and everybody has a different strategy, and there's a number of different medications that are thrown into the pot, and things like whether you wrap a patient or whether you ultrafiltrate a patient, they have major implications. What we did was we started basically the same way that we started with our intraoperative protocol, and we said we need something more specific and more consistent. And so we sat down with the perfusionists. One of the leaders of this from our side was a guy named Slava Borodka, and he created a goal-directed perfusion protocol along with the perfusionist team. And the way that this works is that you focus on delivering a certain amount of oxygen at all times while you're on bypass. You focus on a certain blood pressure goal, and you achieve that in a very specific way. We really limit the amount of wrapping that we do. We really limit the amount of ultrafiltration we do and hemoconcentration. And those strategies have led to a substantial reduction in acute kidney injury. That's something that he's published on previously. And again, we think that it marries well to this concept of how are you managing your goal-directed fluids. A goal-directed fluid, and again, I'm using air quotes here again, is kind of moving target. Because I would make the argument that despite all people's well intentions, we still don't have a real great algorithm for this in any surgery. I think that the inception of some of these fluid monitors has been helpful, but I also think that they're not perfect. And particularly in a cardiac patient where you may have a failed pump as a mechanism for this, those algorithms are different. And I can't tell you specifically how they're different because those data don't exist. And so I think to your point, one of the moving targets in where cardiac ERAS is and will be is how do we manage fluids in those patients. Right now, the only thing I can tell you is that, to be as well-intentioned as possible, you shouldn't be too far on the left, meaning you don't give enough, and shouldn't be too far on the right where you give too much. And I know that that's a terrible answer, but genuinely, that's what the data show us right now.
Thanks for listening to Top Med Talk. Don't forget to subscribe. And don't forget, of course, Top Med Talk will be covering the American Society of Anesthesiologists for free, live on edpom.org. So check out live.edpom.org now, and you'll find all of the preparations in place as we get ready for the 9th of October, when we will be covering live the American Society of Anesthesiologists annual general meeting. More details available on edpom.org.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.